Today's lecture focuses on conflict literacy as an essential competency in advanced psychiatric practice. Conflict is not peripheral to what we do as PMHNPs, it is central. Every clinical encounter contains the potential for disagreement, divergence, power imbalance, or competing priorities. These conflicts may arise between patient and provider, within families, among interprofessional teams, or between ethical obligations and organizational constraints. As doctoral-prepared clinicians, we must move beyond reacting to conflict emotionally or defensively. Instead, we must develop structured ways to assess, conceptualize, and intentionally engage conflict. Just as we use diagnostic frameworks to assess psychiatric symptoms, we can use conflict frameworks to assess relational and systemic tension. By the end of this session, you should be able to identify different types of conflict, recognize your role within them, evaluate power imbalances, and select an ethically appropriate response strategy. Conflict is woven into the fabric of psychiatric practice, whether we consciously acknowledge it or not. As PMHNPs, we routinely encounter diagnostic disagreement, family tension, interprofessional conflict, and situations involving significant power imbalance. These conflicts often coexist with legal and ethical constraints, such as involuntary treatment statutes, duty to warn, or mandated reporting requirements. In addition, organizational pressures, such as productivity demands, limited inpatient beds, insurance authorization barriers, and staffing shortages, create structural conflict that directly affects patient care. These pressures may place clinicians in situations where clinical judgment feels at odds with institutional expectations. If conflict is not understood or addressed intentionally, it can escalate into breakdowns in communication, erosion of trust, moral distress, and burnout. Remember, when conflict is approached with structure and awareness, it can enhance clinical reasoning, improve collaboration, and strengthen therapeutic relationships. Conflict literacy allows PMHNPs to engage these moments with clarity rather than reactivity. In the vignette presented, multiple clinicians evaluate the same client but arrive at dramatically different conceptualizations. One attributes the behavior to intrapsychic conflict, another to distorted cognition, and another to dysfunctional family dynamics. Each clinician is drawing from a legitimate theoretical framework, yet disagreement emerges. This scenario illustrates a critical point. Not all conflict reflects incompetence or error. Often, conflict reflects differences in paradigms. In psychiatric practice, theoretical orientation shapes assessment, diagnosis, and treatment planning. When paradigms differ, interpretation differs. As PMHNPs, we frequently occupy integrative roles. We synthesize biological, psychological, social, and systemic perspectives. That integrative function places us in positions where we must recognize and navigate professional conflict without escalating it. Rather than viewing disagreement as a threat, we can view it as an opportunity for deeper analysis. Conflict here signals diversity of perspective. Our task is not to eliminate differences, but to facilitate constructive dialogue and collaborative clinical decision-making. Conflict is commonly misunderstood as hostility, aggression, or interpersonal dysfunction. However, conflict resolution literature defines conflict more broadly. Conflict exists when two or more parties experience differences in beliefs, values, positions, social identities, or interests. These differences may be real or perceived. In psychiatric practice, many conflicts are rooted in perception. For example, a patient may perceive a medication recommendation as coercive, even when the clinician intends collaboration. A parent may perceive a provider's caution as indifference. These perceptual differences are sufficient to generate conflict. It is also important to distinguish social conflict from intrapsychic conflict. While psychiatry often focuses on internal psychological tension, conflict resolution frameworks address relational and systemic divergence. Our work requires awareness of both. Interpersonal conflict frequently interacts with intrapsychic distress. Before intervening, we must ask, what type of difference is present? Is this a difference in values? A clash of interests? A power struggle? A misunderstanding? Accurate assessment of the nature of the conflict determines the appropriateness of the intervention. The language we use to describe conflict interventions shapes how we approach them. The term conflict resolution implies that the goal is to end or settle the disagreement. In some clinical situations, resolution is possible and appropriate. For example, clarifying a misunderstanding about medication side effects may resolve a dispute. Conflict management, however, implies strategic containment. Some conflicts are chronic and embedded within ongoing relationships. Consider long-term family dynamics in schizophrenia or bipolar disorder. The goal may not be elimination of disagreement, but stabilization and functional coping. Conflict engagement represents a more nuanced approach. Engagement emphasizes constructive participation rather than avoidance or suppression. It recognizes that some tensions are enduring and require ongoing dialogue rather than a one-time solution. In psychiatric practice, engagement is often the most realistic goal. Families may never fully agree. Patients may continue to struggle with ambivalence. Interprofessional differences may persist. Our role is to facilitate structured, respectful engagement rather than reactively seeking immediate resolution. Understanding these distinctions helps prevent unrealistic expectations and supports ethical, sustainable clinical practice. Restorative justice originates from legal and community-based models that prioritize healing over punishment. Rather than focusing solely on rule violation and consequences, restorative approaches emphasize dialogue, accountability, and relationship repair. Although restorative justice is often associated with criminal contexts, its principles are highly relevant to psychiatric practice. In mental health settings, we frequently encounter behaviors that disrupt families, schools, or communities. The instinct may be to respond with control or exclusion. However, a restorative lens asks different questions. Who has been harmed? What needs to be repaired? How can accountability occur without humiliation? For example, in adolescent behavioral crises, a punitive approach may escalate resistance and reinforce shame. A restorative approach emphasizes understanding impact, promoting responsibility, and rebuilding trust. This aligns closely with trauma-informed care principles. As PMHNPs, incorporating restorative thinking helps balance safety and dignity. It encourages structured accountability while preserving therapeutic alliance. This mindset shift transforms conflict from a threat into an opportunity for relational growth and system stabilization. There are 4 primary approaches to understanding and responding to conflict: power-based, rights-based, interest-based, and transformative. These frameworks provide a structured way to analyze what is happening in a conflict situation and to determine how best to intervene. A power-based approach relies on authority, hierarchy, or control of resources. A rights-based approach relies on rules, laws, policies, or ethical codes. An interest-based approach focuses on underlying needs and collaborative problem-solving. A transformative approach focuses on empowerment, recognition, and growth within relationships. Most psychiatric conflicts do not fall neatly into only one category. Instead, they often involve a blend of these approaches. For example, involuntary hospitalization involves power and rights. Medication negotiation involves interests. Family therapy may lean toward transformation. The key clinical question becomes, which framework is currently dominating this conflict? And is that framework ethically appropriate for the situation? Developing fluency in these 4 approaches allows you to move intentionally rather than reflexively when conflict arises. A power-based approach to conflict relies on authority, hierarchy, or control of resources to determine outcomes. In this model, the party with greater institutional, legal, or structural power influences or determines the resolution of the conflict. In psychiatric practice, power-based interventions are sometimes necessary. Examples include involuntary commitment, emergency medication administration, seclusion and restraint decisions, or discharge determinations made under safety constraints. These decisions are grounded in statutory authority and clinical responsibility. However, power-based approaches carry significant ethical weight. Overuse or misuse of power can damage trust, reinforce trauma, and undermine therapeutic alliance. Patients with histories of coercion or marginalization may experience power-based interventions as re-traumatizing, even when clinically justified. The goal is not to eliminate power from psychiatric practice, because that would be unrealistic, but to use power transparently, proportionally, and ethically. Before employing a power-based intervention, ask, is this necessary for safety? Is there a less coercive alternative? How can I preserve dignity and voice while exercising authority? Understanding when and how power is operating is foundational to advanced psychiatric leadership. A rights-based approach to conflict relies on formal rules, laws, policies, and ethical standards to determine what is fair and appropriate. Rather than asking who has authority, this approach asks, what does the law or ethical code require? In psychiatric practice, rights-based frameworks are central. Informed consent, confidentiality, HIPAA protections, guardianship statutes, duty to warn, and involuntary treatment criteria are all grounded in rights-based reasoning. When disagreements arise, clinicians may turn to policy manuals or legal standards to guide action. Rights-based approaches promote procedural fairness and protect vulnerable individuals. They are essential in ensuring that patients' autonomy and legal protections are upheld. However, rights-based disputes can become adversarial. When parties argue strictly from rights positions, collaboration may diminish, and the interaction may feel more like litigation than therapeutic engagement. For example, a patient may assert the right to refuse medication, while a provider emphasizes the right to safety for the patient and others. Both positions are grounded in legitimate rights. The challenge becomes balancing competing rights without escalating the conflict. As advanced practitioners, we must know the law and ethical standards thoroughly. At the same time, we must recognize when rigid rights-based positioning is intensifying conflict and consider whether an interest-based or transformative approach might facilitate more constructive engagement. An interest-based approach shifts the focus from positions to underlying needs. A position is what someone says they want. An interest is why they want it. In psychiatric care, patients, families, and providers frequently present with firm positions. A teenager may say, "I'm not taking medication." A parent may say, "She has to take it." A clinician may say, "This is the recommended treatment." If we remain at the level of positions, the interaction becomes polarized. An interest-based approach asks deeper questions. What need is driving the teenager's refusal? Is it autonomy, fear of side effects, distrust of authority? What need is driving the parent's insistence? Safety, academic performance, relief from chaos? What need is driving the clinician's recommendation? Symptom stabilization, risk reduction. Interest-based negotiation aligns closely with motivational interviewing and shared decision-making. It prioritizes collaboration and mutual gains rather than winning or enforcing compliance. This approach does not mean abandoning safety standards. Rather, it means engaging underlying concerns first, which often reduces resistance and builds alliance. In many outpatient psychiatric settings, interest-based engagement is the most therapeutically effective model. The transformative approach to conflict focuses not primarily on solving the dispute, but on strengthening the individuals and relationships involved. It emphasizes two core processes: empowerment and recognition. Empowerment refers to helping individuals regain clarity, confidence, and a sense of agency. Recognition refers to helping individuals understand and acknowledge the perspective of the other party. When both occur, the conflict itself may shift in tone and intensity. In psychiatric practice, this approach is particularly relevant in family work and long-term therapeutic relationships. Consider a family experiencing repeated crises related to a member's bipolar disorder. A purely problem-solving approach might address medication adjustments and crisis planning. A transformative approach would also attend to communication patterns, reactivity, and emotional differentiation. This approach aligns well with systems theory and relational psychotherapy models. It does not ignore practical solutions, but it recognizes that durable change often occurs when people experience growth in how they engage one another. For PMHNPs, transformative engagement means facilitating dialogue that strengthens resilience, increases mutual understanding, and reduces chronic escalation. It reflects advanced relational competence and leadership maturity. Mediation is a structured conflict intervention process in which a neutral third party facilitates communication between individuals in conflict. The mediator controls the process, but does not control the outcome. The parties retain decision-making authority. Several core principles define mediation. It is typically voluntary, meaning parties choose to participate. It is confidential, creating psychological safety for open dialogue. It emphasizes neutrality or impartiality of the mediator. And it prioritizes self-determination, meaning the resolution belongs to the participants, not the facilitator. In psychiatric settings, PMHNPs often perform informal mediation roles. For example, during family sessions, we facilitate dialogue between parents and adolescents. In interdisciplinary rounds, we may help reconcile differences between nursing staff and physicians. In outpatient settings, we mediate between patient expectations and clinical recommendations. Understanding mediation as a structured process helps us move from reactive facilitation to intentional facilitation. Rather than simply managing emotional exchanges, we guide conversation in a way that promotes clarity, mutual understanding, and constructive problem-solving. Neutrality is a foundational concept in mediation, but it is also one of the most complex. Neutrality typically refers to the mediator's independence and lack of favoritism toward either party. It implies fairness, impartiality, and balanced attention. In psychiatric practice, however, neutrality is not always straightforward. As clinicians, we are ethically bound to prioritize safety, adhere to legal standards, and follow evidence-based practice. This inherently shapes our positioning. For example, if a patient is actively suicidal, we cannot remain neutral between the patient's desire to leave and the safety imperative to intervene. Therefore, neutrality in psychiatric settings often means procedural neutrality rather than moral neutrality. We strive to provide balanced voice, equitable attention, and fair process, even when the clinical decision must prioritize safety. Self-awareness becomes critical. We must recognize our own biases, theoretical preferences, and emotional reactions. Without self-reflection, we may unconsciously align with one party or escalate tension. Advanced practice requires distinguishing between being neutral about the outcome and being neutral about the process. Even when clinical judgment guides the outcome, the process can still honor dignity, transparency, and respect. One of the most important responsibilities of a mediator, or any clinician facilitating conflict, is attention to power imbalance. Not all parties enter conflict situations with equal voice, authority, or safety. Power imbalances may be structural, such as age differences between parent and child, legal authority differences between clinician and patient, or cultural and language barriers. They may also be relational, such as in cases of intimate partner violence, coercive control, or financial dependency. If power imbalance is ignored, mediation can unintentionally reinforce harm. For example, encouraging equal dialogue in a situation where one party has a history of intimidation may silence the more vulnerable individual. In psychiatric practice, power balancing requires careful assessment. We may need to adjust seating arrangements, set structured speaking rules, provide private check-ins, or even determine that joint dialogue is not safe. Power balancing does not mean eliminating all authority. It means recognizing disparities and ensuring that vulnerable voices are protected and heard. Trauma-informed care principles align closely with this responsibility. Advanced practitioners do not assume fairness. They actively assess and structure for it. As PMHNPs, we shift roles frequently in conflict situations, often without consciously naming the role we are occupying. Conflict resolution literature identifies several roles helping professionals assume: negotiator, advocate, mediator, facilitator, evaluator, and expert. A negotiator is directly involved in resolving disagreement. When you collaborate with a patient to adjust medication, develop a safety plan, or establish treatment goals, you are negotiating as a decision maker. An advocate supports one party's interests. When you appeal an insurance denial, request accommodations, or argue for a higher level of care, you are intentionally aligned with that party's needs. A mediator is a neutral third party who facilitates communication without determining the outcome. In family sessions, when you structure dialogue between a parent and adolescent and help them hear one another without taking sides, you are mediating. An evaluator assesses and renders an informed opinion that may influence outcomes. In suicide risk assessments, custody evaluations, or capacity determinations, neutrality reflects objectivity in assessment, not neutrality of outcome. A facilitator guides group process more broadly, such as during interdisciplinary rounds, when you help a team move through disagreement constructively. An expert provides specialized knowledge to inform decisions, such as when you consult with primary care about psychiatric management. Role clarity is critical because each role carries distinct ethical obligations. Advocates align, mediators balance process, evaluators prioritize objectivity. Confusing these roles, such as advocating while claiming neutrality, creates ethical risk. Advanced psychiatric leadership requires conscious role awareness. Before entering conflict, pause and ask, what role am I in? Is it appropriate? And do others understand it? That clarity reduces boundary confusion and strengthens professional integrity. Interprofessional conflict is common in psychiatric settings and is often rooted in differences in training, theoretical orientation, risk tolerance, and scope of practice. Diagnostic disagreement, such as bipolar disorder versus borderline personality disorder, is a frequent source of tension. Resource allocation can also generate conflict. Decisions about admission criteria, discharge timing, staffing coverage, and prioritization of consults may create friction among team members. Additionally, scope of practice boundaries can create implicit or explicit power struggles. When unmanaged, interprofessional conflict can compromise patient safety, fragment care, and reduce team morale. However, when addressed constructively, it can improve clinical reasoning and lead to more comprehensive care planning. Structured dialogue is essential, clarifying clinical rationale, inviting multiple perspectives, and focusing on shared goals, such as patient safety and functional improvement, reduces polarization. It is also helpful to distinguish between disagreement over data and disagreement over values. As advanced practice nurses, you are often positioned as bridges within teams. Your dual lens of biological and psychosocial understanding uniquely equips you to facilitate integrative discussion rather than escalate competition. Conflict literacy in interprofessional settings strengthens leadership presence and protects collaborative care. Family conflict is inherent in psychiatric practice because mental illness affects entire relational systems, not just individuals. Medication refusal, Disagreements about hospitalization, custody disputes, boundary violations, and enmeshment frequently emerge during care. Family members often hold different perceptions of the problem and different priorities for intervention. A parent may prioritize safety and academic functioning. A young adult may prioritize autonomy and independence. A spouse may prioritize stability and predictability. These competing interests generate predictable tension. From a systems perspective, conflict often reflects anxiety within the family unit. Heightened emotional reactivity can lead to triangulation, blame, or scapegoating. As PMHNPs, we must recognize these patterns and avoid being pulled into alliances that reinforce polarization. Effective engagement requires clarity about roles, structured communication, and attention to power dynamics within the family. It also requires maintaining therapeutic neutrality in process while upholding safety standards. Rather than viewing family conflict as a disruption of care, we can conceptualize it as diagnostic information. How a family argues often reveals as much as what they argue about. Structured engagement transforms conflict into a clinical tool rather than a barrier. Trauma-informed care principles are essential when engaging conflict in psychiatric settings. Many patients have histories of interpersonal trauma, coercion, systemic marginalization, or institutional mistrust. Conflict situations can activate these experiences and escalate defensive responses. A trauma-informed approach emphasizes safety, transparency, collaboration, empowerment, and choice whenever possible. Even when power-based interventions are clinically necessary, the manner in which they are implemented significantly affects patient experience. For example, explaining the rationale for involuntary admission clearly and respectfully, acknowledging the patient's fear or anger, and outlining next steps can reduce re-traumatization. Similarly, ensuring that patients feel heard, even when their request cannot be granted, preserves dignity. Trauma-informed conflict engagement also requires attention to cultural context. Historical injustices and systemic inequities influence how authority and medical decision-making are perceived. Advanced practitioners integrate safety and compassion simultaneously. Conflict is not handled through dominance or avoidance, but through structured, emotionally regulated, ethically grounded engagement. In this case, an adolescent refuses prescribed medication while a parent insists on adherence, illustrating layered conflict at multiple levels. The teen's position is refusal, the parent's is insistence, the clinician's is a treatment recommendation based on clinical judgment. If we focus only on positions, the interaction polarizes into compliance versus defiance. Shifting to interest changes the frame. The teen may value autonomy, identity, or avoidance of side effects. The parent may prioritize safety, stability, and academic functioning. The clinician may focus on symptom control and risk reduction. Power imbalance is inherent. Parents hold legal authority, clinicians prescriptive authority, and the adolescent occupies a developmentally vulnerable yet emerging autonomous role. Ignoring this imbalance can escalate conflict or silence the teen's voice. Using a strictly power-based approach, "You must take this medication," may intensify resistance and fracture alliance. A purely rights-based approach, "I have the right to refuse," may minimize legitimate safety concerns. An interest-based approach explores fears, values, and options while maintaining safety standards. A transformative approach goes further by strengthening mutual understanding between parent and adolescent. If imminent safety risk is present, a power-based intervention may be ethically justified. That is not a failure of collaboration, but a responsibility of practice. However, advanced psychiatric care does not stop at authority. Even when power must be exercised, we continue interest-based dialogue to preserve dignity, alliance, and long-term adherence. Conflict literacy means knowing which framework you are using, why, and how to minimize unintended relational harm. In this case, imagine disagreement within the treatment team regarding diagnosis. One provider conceptualizes bipolar disorder, another borderline personality disorder. This is not trivial. It affects treatment planning, medication management, prognosis, and stigma. First, identify the framework operating in the disagreement. If the conflict centers on authority, I am the attending and this is the diagnosis, it is becoming power-based. If it centers on DSM criteria or standards of care, the diagnostic criteria support bipolar disorder. It reflects a rights-based framework grounded in professional guidelines. If the discussion shifts to underlying clinical concerns, what symptoms concern us most? What risks are driving our thinking? The team is engaging in an interest-based approach. A transformative approach goes further by examining relational dynamics. How does disagreement affect collaboration? Are theoretical biases shaping interpretation? How can mutual respect be maintained despite diagnostic divergence? When diagnostic conflict arises, the key question becomes, how do we prevent this from becoming about professional identity rather than patient safety? Interprofessional conflict is often less about data and more about paradigm, ego, and perceived authority. Advanced practice requires emotional regulation, intellectual humility, and structured dialogue to keep the patient, not professional positioning, at the center of the discussion. This case involves involuntary admission, one of the clearest examples of layered conflict in psychiatric practice, where safety and autonomy are in direct tension. The dominant framework is power-based. The state grants authority to restrict liberty when safety thresholds are met. It is also rights-based. Statutory criteria, due process protections, evaluation timelines, and documentation standards safeguard against arbitrary use of power. Yet even within this structure, interest-based and transformative elements remain relevant. A patient's refusal may stem from fear, mistrust, trauma history, or stigma. If we engage only through authority and legal explanation, we risk escalating distress and reinforcing adversarial positioning. Advanced psychiatric practice requires dual awareness. We must protect safety and adhere to statutory criteria while simultaneously preserving dignity, voice, and relational continuity. The critical question becomes, how can you exercise involuntary authority in a way that minimizes re-traumatization and protects the therapeutic alliance? This requires attention to language, tone, transparency, and post-crisis repair conversations. The conflict does not end when the paperwork is completed. The relational impact persists. This case illustrates that conflict literacy is not theoretical. It directly shapes patient outcomes and long-term engagement. Conflict in psychiatric practice occurs not only at the individual or family level, but also at the systems level. Organizational pressures create structural conflict that shapes clinical decision-making. Productivity demands may pressure clinicians to shorten visits or increase caseloads. Insurance restrictions may limit treatment options. Bed shortages may force premature discharge decisions. Staffing constraints may increase risk exposure. In these cases, the conflict may not be interpersonal, it may be systemic, yet the clinician experiences it personally. Tension between clinical judgment and institutional policy represents conflict between professional values and structural constraints. Which framework dominates? Organizational conflicts are often managed through power-based hierarchies or rights-based policies grounded in contracts and regulations. However, interest-based dialogue at the systems level can be transformative. Engaging administrators in collaborative problem-solving, presenting outcome data, and advocating for patient-centered policy reflects advanced psychiatric leadership. The critical question becomes, when organizational pressures conflict with your clinical judgment, how do you respond without escalating into burnout or moral distress? Conflict literacy at the systems level protects both patients and providers by aligning ethical practice with sustainable systems engagement. Conflict is culturally mediated. Cultures differ in how they interpret authority, disagreement, emotional expression, and confrontation. What feels assertive in one context may feel disrespectful or threatening in another. Some cultures emphasize harmony, indirect communication, and group cohesion. Others prioritize directness, autonomy, and individual expression. These differences shape how conflict emerges and how it is resolved. In psychiatric settings, cultural perceptions of mental illness, medication, authority, and family roles significantly influence conflict patterns. In collectivist contexts, family authority may be prioritized over individual autonomy. In other settings, asserting personal rights is expected. Power dynamics are also culturally shaped. Historical trauma, systemic racism, and medical mistrust influence how authority is perceived. A power-based intervention may be interpreted very differently depending on lived experience. Advanced psychiatric practice requires cultural humility. Rather than assuming conflict behaviors reflect pathology or resistance, we must ask how cultural context is shaping the interaction. A critical reflective question is, how might your own cultural background influence the conflict framework you default to under stress? Conflict literacy includes awareness of cultural lens, both the patient's and your own, so that clinical authority does not unintentionally reproduce harm. Conflict is often framed as something to eliminate or avoid. However, when engaged constructively, it can catalyze growth at individual, team, and systems levels. Individually, conflict increases self-awareness. Patients may gain insight into values, fears, and relational patterns. Families may recognize cycles of reactivity and develop healthier communication. Clinicians may identify implicit biases or emotional triggers shaping decision-making. At the team level, constructive disagreement strengthens clinical reasoning. When explored respectfully, differing diagnostic perspectives improve assessment accuracy and reduce cognitive blind spots. At the organizational level, conflict can expose structural weaknesses and inspire improvement. Complaints and grievances often reveal meaningful service gaps. The difference between destructive and constructive conflict lies not in disagreement itself, but in how it is handled. Emotional regulation, curiosity, structured dialogue, and ethical clarity transform tension into learning rather than breakdown. A key reflective question is, what is this disagreement teaching us about needs, systems, or vulnerabilities? Conflict literacy allows PMHNPs to convert tension into growth instead of escalation, strengthening both clinical outcomes and professional integrity. I want to offer a practical framework you can apply immediately when conflict arises. Pause and ask 5 questions. First, what conflict framework is dominating? Power-based, rights-based, interest-based, or transformative? Naming the framework clarifies the dynamics. Second, what role am I occupying? Am I acting as negotiator, advocate, mediator, evaluator, or authority figure? Role clarity prevents ethical confusion. Third, where is the power imbalance? Who holds authority, and who may feel vulnerable or silenced? Have I structured the interaction to ensure fairness and psychological safety? Fourth, what is ethically required? Are there legal standards, professional obligations, or safety concerns that must guide the decision? Fifth, what promotes safety and dignity simultaneously? Even when authority must be exercised, how can voice, transparency, and relational continuity be preserved? These questions shift you from reactivity to intentional leadership. Conflict literacy is not about avoiding disagreement. It is about engaging it with clarity, emotional regulation, and ethical awareness. Advanced psychiatric practice requires both clinical expertise and relational sophistication. This framework supports both by aligning decision-making with integrity and patient-centered care. I want to close with this idea: conflict is not a failure of care. It is not evidence that something has gone wrong. It is an expected and often necessary component of complex psychiatric practice. You will encounter conflict not only with patients and families, but also with coworkers. Disagreements may arise over diagnosis, treatment planning, documentation standards, productivity expectations, scope of practice, or leadership decisions. At times, conflict feels personal, especially when it touches professional identity or perceived competence. When coworker conflict arises, the same framework applies. Ask yourself, is this power-based? Is this rights-based? Are we arguing policy, defending identity? Or is there an underlying interest that has not yet been named? Reactive responses escalate tension. Structured engagement preserves professionalism. Conflict literacy allows you to separate disagreement from disrespect and advocacy from ego. Leaders do not avoid coworker conflict. They regulate themselves, clarify roles, and return conversations to shared goals: patient safety, ethical care, and professional integrity. As you move into independent practice, remember, you may not eliminate conflict with patients, families, or colleagues, but you can elevate how it is engaged. That capacity reflects doctoral-level psychiatric leadership.